Hi everyone. Thank you for having me. So I want to talk about how rapidly Omicron is spreading in the world in King County. So we think that the very first case of Omicron was in Southern Africa around October 1st and has rapidly spread throughout South Africa and then getting into other places. London is a few days ahead of us in Seattle, but it looks like Seattle and King County are going to be a bit ahead of the curve in the US as well. Generally, we've been looking and seeing these very rapid 2 to 3 day doubling times of Omicron cases throughout South Africa, UK, Germany, Denmark, US. And now with really kind of very good data coming out of UW Virology lab and Seattle Flu Study, we can really see what's happening in a lot of detail in King County. So this is data from my colleagues. It's not my data, but thank you for generating this. So this is using S gene target failure. So tests have multiple targets along the SARS-CoV-2 genome, and you can have probable or quite likely Delta versus Omicron distinction based upon just this PCR assay. You have to wait for genotype for full genome sequencing to be sure, but this is highly likely to be Omicron versus not Omicron. I have it down as probable. So this is looking at 2,000 assays run over the course of December so far, with about 270 probable Omicron hits. And the really important thing to see is how quickly the proportion of Omicron has been rising in King County samples during December. We get the same about 2.5 day doubling time that in King County as we've seen in South Africa, UK, elsewhere. Now up to, as the last date that we can have a kind of a firm estimate of approaching 50%, almost about 30% on December 13th. But the important thing is really not that 30%, but is much more this rate of doubling. We can partition daily case counts reported by the county into what we think is Delta and what we think is Omicron based upon these frequencies. And you can just see how rapidly the increase in Omicron has been. Again, we get about a 2.4 doubling rate. So we're just now going to be hitting the point where Omicron starts to kind of push above Delta cases. It was kind of hidden and submerged by Delta in the last couple of weeks, but its rate of growth will quickly make it visible. So if we just do like the ridiculously simple thing and extend this line, exponential growth won't go on forever. This will start to cap out, but I do think we have a week or two or more of this exponential growth left. And we just extend this line in 1 week's time. On, say, December 23rd, we're up to over 2,000 daily cases in King County. This is 3 times the peak of Delta in August and is going to be quite high. So we don't know exactly what case counts will be into January in King County and in the US, but I'm certain it will be the highest case counts we've seen throughout the pandemic. And what we're really kind of waiting for now is to see how that translates into severity. I'm hopeful that severity will be quite reduced, mainly due to population immunity, but we'll have to kind of wait to see exactly what it comes in at. And I'll stop there.
Great, thank you so much. We'll go ahead and go to Dr. Greninger.
Sure. So as Trevor said, basically, I'm coming from the University of Washington Virology Lab and talking about some of the laboratory assays that we're doing. Trevor talked a little bit about the S gene target failures, where there's an assay that has targets 3 different parts of the virus, and one part will drop off in Omicron. It also dropped off in Alpha. And there are a handful of other types of viruses where it will drop out as well. So as Trevor said, it's not a perfect measurement, but with these prevalences of Omicron that are sequence confirmed Omicrons, the S gene target failure assay looks a lot better as a predictor. And so we are running all of our positives that we can through the S gene target failure assay to look for that. And then we're sequencing, though that often takes like a 5 to 7 day time frame, if not a little bit longer. So as you saw right there on the data, the most recent data that we pushed yesterday were samples that were collected December 13th. And I'll also just say, from a number of samples coming to the lab, the number of collections, the number of cases we're seeing, the collections are as high as they've been really during the entire pandemic yesterday and the day before. and the number of cases as well have increased rapidly, and the positivity rates increased rapidly in the last week or two. So it all squares with, sort of really watching out for the coming days. And this is sort of our last chance to do something about that. So I'm happy to take any questions about the assays. I think it's also worth saying that we sequence a little over 100 Omicron so far. I think we've only had maybe a 1 or 2 samples where the S gene target failure was not an Omicron. So it's a rare phenomenon, honestly, at this point. So just wanted to talk a little bit about the assays, and with that, I'll pass it back.
Great, thank you very much. And now to Dr. NEME.
Hi, good afternoon. Thank you for having me. I wanted to address the hospital capacity challenges that we've had over the past 2 years. We've lived in very full hospitals, and although our numbers currently for COVID infected patients in the hospitals have decreased, for instance, today we have 22 patients across all 4 hospital campuses at UW-Medicine. We have been operating at a full or over full capacity for several months in many areas of the state. This has to do with staffing shortages, but also an increase of transfers from other areas of the state of Washington, and also neighboring state hospitals that are actually dealing with much higher rates, partly due to lower vaccination rates and also masking mandates. So although there's some hypothesis that Omicron may be associated with a milder disease, any increase in hospitalization rates or hospital utilization will be pretty challenging for us and highly concerning, because again, our healthcare workforce is already overtasked with the number of patients that we're seeing, again, not necessarily associated with COVID, but also the staffing shortages. And some of the staffing shortages have to do with any COVID infection in a healthcare professional that even though it might be mild, that takes that person offline and therefore it cannot work. So it's never been a better time to get a booster and really follow the guidelines that we have set forth by Dr. Duchin and his team. Thank you.
Excellent. Thank you so much. And I'll go ahead and turn it over to Dr. Duchin.
Thanks, Sharon. And I just want to start by thanking our amazing colleagues from the university, my friend, Dr. NEME, Dr. Greninger, and Dr. Bedford for what they're doing for not only the patients of the University of Washington, but for the people of our region by providing this excellent virology work and clinical support. I also want to start by acknowledging that today's news is not what any of us wants to hear after 2 long and exhausting years of COVID-19. Despite all we've been through, Omicron is throwing a new challenge at us at a most inconvenient time. So I have 2 main messages today. The first is that the Omicron outbreak we've been talking about is no longer theoretical. It's real, it's here, and it's moving fast. The second main message is that we can all take steps that will reduce our personal risk and the risk to others. Since we recognized the first Omicron case in King County just under 2 weeks ago, UW-Medicine is now finding almost 40% of the isolates they're screening are likely Omicron. And as Dr. Bedford described, he's predicting a record-breaking number of cases within a week or 2. Now, our recent decline in cases has reversed this week with about twice as many cases reported as last week, consistent with the observations that our UW colleagues are making. Cases are up 50% since Thanksgiving, and we're about to re-enter the high transmission category after dropping to substantial in early November. As Dr. Bedford described, we expect the number of cases to double every 2 to 3 days and to see an increasing number of outbreaks. Hospitalization and death rates have been relatively stable over the past month, but as you know, these are lagging indicators by several weeks behind changes in case counts. And as Dr. NEME described, we currently have twice as many patients with COVID-19 in King County hospitals as we had before the summer Delta surge, and hospitals in King County and throughout the region continue to report extremely high patient volumes, with 98% of critical care beds filled. As we've emphasized in the past, we don't yet have all the answers about Omicron, and much remains uncertain about how exactly this variant will affect us. But we now know that we have rapid community spread of Omicron locally, which is a significant problem because of how many people could be rapidly infected. And we want to remind everyone that there are steps we are familiar with and that we can and should take now to decrease our risk. Omicron, like Delta, is an airborne disease. It spreads primarily in indoor spaces, but it's even more infectious. It's important to recognize that we do not yet have a clear picture of the severity of illness Omicron causes compared to Delta. We do know that among younger and vaccinated people, most reported infections have been mild, but that's also true of Delta. We also don't know yet about the severity in older adults, but these infections will likely be more severe than in younger people. Now, I'm very gratified to remind that King County residents will benefit greatly from the fact that 86% of people 16 years of older are fully vaccinated. But there are still approximately 160,000 adults who've not initiated a vaccination series and 250,000 who have not yet completed their series. And Omicron is going to find many of these people. We know that Omicron evades antibody protection from past infection, and vaccination has been recommended for people with past infection for this reason. Vaccination of previously infected people provides a better immune response against variant viruses. We also know that although vaccines have decreased effectiveness against infection with Omicron compared to Delta, they should continue to protect against what's most important, serious infections. So we can expect to see an increasing number of infections in people who've had past infection and breakthrough infections in vaccinated people. But we should also expect that for the majority of us who are vaccinated, our vaccines will continue to work against severe infection. But even if only a small proportion of cases are severe, when so many people are infected in such a short time frame, it can lead to a very large number needing hospital care at once, overloading our already stressed healthcare system and potentially compromising the life-saving care it needs to deliver when we need it. For this reason, the single most important thing we can do is to get vaccinated and boosted when eligible, even if you've previously had COVID-19. But vaccination alone will not be enough to limit the rapid spread of Omicron that's underway. Vaccination needs to be layered in combination with other strategies that we know work to reduce the risks to individuals and to our community. We need to take advantage of as many layers as we can and apply them as effectively as we can. If there's anything that we can do to improve our COVID prevention measures at home, at work, or in the community, this is the time to do it. Businesses and healthcare facilities should plan for the impact on their workforce and reducing risk in the workplace. We should take steps to improve indoor ventilation and air quality everywhere, businesses, workplaces, and at home. Schools may also see impacts from more cases in staff and students after the winter break. Now is a good time to reinforce risk reduction measures, including universal indoor masking, ventilation, and communicating that students, teachers, and staff should stay home when they have any signs of illness. For the public, we know many are planning to gather with friends, family, and loved ones over the holiday season. If you do gather, please do it as safely as possible. Do what you can to limit the number and size of indoor gatherings. To make gatherings safer right now, avoid crowded indoor spaces during the holiday season, limit the number of gatherings, and when possible, do a rapid test the day of the gathering. Gathering will be safer in larger, well-ventilated spaces. You can open windows for fresh air. COVID-19 levels are high throughout the US, both from Delta and now the spreading Omicron variants, and travel poses additional risks. So where possible, postponing travel, especially if to or from areas with high levels of COVID-19, can also help. Use a well-fitting and high-quality face mask or respirator when gathering indoors and in indoor public spaces. KN95, KF94, and even N95 masks are now widely available. And in King County and Washington State, everyone 5 years of age and older, regardless of vaccination status, is required to wear a mask in indoor public settings like grocery, retail, theaters, and entertainment establishments, and at outdoor events with 500 or more people. If you're eligible, sign up to get a booster appointment. And remember to take extra precautions for the higher risk people in your life. With the large rise in cases expected over the next few weeks, more of us will test positive. If you do, review information on how to take care of yourself and others you live with. And that's available on our website, and information is available from CDC. I know our colleagues at UW can provide information as well. Remember that half or more of infections are spread from people before they have symptoms. So symptom screening, although important, does not identify everyone who can spread COVID-19. Rapid testing before gathering can help identify people with COVID-19 early. And finally, a reminder that the best place to find and book appointments for all doses of the vaccine is at vaccinelocator.doh.wa.gov or on our King County vaccination webpage. So with that, I will pause and welcome questions for all of our panelists.
Thank you very much, Dr. Duchin. And for our media, if you can let us know your outlet, that's always helpful. So we'll start with Nicole Jennings. You can go ahead.
Hi, I'm with Cairo Radio. My question is for the breakthrough Omicron cases that we've seen. Is this mostly in people who just had their first 2 doses or 1 dose J&J, or is this people who have also been boosted?
Santiago, do you want to speak about that? I mean, we don't have local data on that quite yet, but there's international data. And I don't know if you want to take that, Santiago, or I can if you prefer.
Yeah, I don't think we have the data, but I don't know, Jeff, if we want to add something more specific.
Yeah, no, very little information about booster doses internationally. Most of the data we have comes from outbreak reports from other countries where they're reporting high proportions of vaccinated people, some of whom were boosted. So, but we can't really give you specific breakdowns of boosted versus unboosted. It's clear that the current vaccines lose some of their effectiveness against infection, but infection per se is not the most important thing. Serious infection is the most important thing. And we believe that the evidence is showing the vaccines will provide meaningful protection against serious infection, hospitalization, and death. So that is very encouraging and will protect many of us in highly vaccinated communities. But as I said, there's still so much to learn about this virus. We will be getting more precise data about the effectiveness of vaccines after 1, 2, and 3 doses and the time since last dose as this outbreak unfolds.
Thank you. We'll take a question from Evan Bush. Evan, you can go ahead. Evan may be having some audio. Let's come right back to you, Evan, and we'll try you in just a moment. Let's go to Joshua McNichols.
Yes, I'm wondering for businesses, this is Joshua from KUOW. For businesses that are considering bringing workers back in January, is this a bad idea? And why just express caution and not, impose some kind of a rule like we had earlier in the pandemic?
I guess I'll take this one, and please, anyone, feel free to add. It depends on the environment. As I've tried to impress upon people, layered precautions are really important, and the environment in which we gather is really important. So having good ventilation, good indoor airflow, and using high quality masks and respirators and distancing can significantly reduce the risk in indoor locations. Being vaccinated, of course, and boosted is the most important measure to significantly reduce the risk. But all these layers will be important in the context of Omicron in particular. And so, different environments will have different risk levels. I think all businesses and workplaces should consider what the environment is to their workers, to their customers, if they have customers, to others that might enter the space, and take all the precautions that they possibly can. On the other hand, we provide this information. We know it works. In King County, we have measures in place that other communities are just now implementing around indoor mask mandates vaccine requirements for many workers and our vaccine verification program that will help. But we also recognize significant economic, psychological, behavioral health, and social consequences of additional mandates. And so we're hoping that the information that we're providing today about how to reduce risk will allow people to make appropriate decisions about how to protect themselves and those in their workplaces, in their families, and in their social circles that will adequately protect our community, which is very highly vaccinated.
If I may add, I also wanted to share that at UW Medicine, when we see infections in healthcare workers, the vast majority do not happen at the hospital. They occur outside when people are socializing, unmasking. So we really haven't seen a significant number of infections really that occur in the hospital with colleagues. It's more outside of the doors of the hospital when the mask comes off. So thank you.
Thank you very much. We'll go back to Evan Bush. You can go ahead.
Hi, thanks so much. I'm with NBC News. Trevor, I was wondering how far ahead of other US cities do you think that Seattle is? And then Jeff, I was wondering if you could walk us through if you considered more restrictive measures and if the strategy is to flatten the curve at this point.
Yeah, only a few days. So it looks like New York City's ahead of Seattle. It looks like Rhode Island might be as well. And you can actually probably capture much of this through travel connections. So if you look at travel connections to Johannesburg, and we see London kind of very high up the list, and it makes sense that London is so early, and Europe being generally before the United States. It is a little surprising if having Seattle be where we are, kind of as close behind New York. I suspect much of this is just that it's basically Seattle and Yale that have great S gene target failure data, which is, say what you will about that. But the rate of doubling is such that I'd expect things to light up across the United States very soon, first in well-connected cities and then spreading to more rural parts shortly thereafter.
Thanks, Trevor, and hi, Evan. I think with the respect to your question about more restrictive measures and flattening the curve, the key strategy really is to slow the spread right now. We know that we're not going to stop the spread, but again, the community here is very highly vaccinated. We expect that vaccinated people will be rather well protected, but there are significant numbers of unvaccinated and other vulnerable people, as well as previously infected who can become reinfected at a much higher rate than they would be expected to be reinfected with Delta, for example. And it's this large number of people who are getting, who will be infected at one time. That's the concern. And that is why we're asking people to consider the risk reduction measures, multiple risk reduction measures, not just one or two, but taking multiple steps to decrease the spread of this virus and slow it down. We are not at this point considering additional measures. As I said, we already have several measures in place that other cities don't have that they're going to. You probably heard about LA and New York adding indoor mask mandates. This is something we already have in place. This is one of the most effective interventions that a community can take if they wear them, and particularly if they're high quality masks. So at this point, no. But as with everything else about the COVID-19 pandemic, things change very rapidly. And if for some reason we believe that there are additional measures that we could take that would have the appropriate cost benefit ratio, we will consider them.
Great, thank you very much. Let's go to Suzanne. I'm wondering if this is Suzanne Fallon. You can go ahead. Okay, we'll come back to Suzanne. Let's go to Jay Thompson. Maybe it's Joey Thompson. Just guessing here from these names. Go ahead.
Actually, can I get to add one thing back to Evan?
Absolutely, go for it.
Not in the context, Evan, not in the context of mitigation, but we are looking at some policy change. For example, the Department of Health recently changed their policy in response to these wrestling associated outbreaks, which are likely Omicron driven, if not wholly, to a great degree, to require more frequent testing of athletes, both vaccinated and unvaccinated athletes, and to reinforce the requirements around mask wearing in the sports and high school environment. And we're also looking at a potential test back to work policy for healthcare workers, for example, and other critical care workers, where now people have to be out isolated for 10 days after the symptom onset. But if in fact we find that this disease is relatively mild in vaccinated people, if they're feeling better, their symptoms are resolving, and they test negative on day 5, let's say, they can get back to the workforce much sooner. So these types of policies are under consideration, and I hope we'll be able to move forward. We're asking everyone to do as much testing as possible, given the limited national supply of testing that we have right now. But it's, I was answering your question mostly in the context of mitigation measures like canceling large-scale events and adding more restrictions around gatherings, mandatory restrictions around gatherings rather than voluntary limitation of gatherings and so on.
Great, thanks so much. Joey Thompson, you can go ahead.
Thank you. And just to clarify about, additional restrictions, I think one of the ones that seems a bit more obvious would be capacity, at bars, which we previously saw in other waves, or, times of hours of operation. So if you could add to that. But then also last time we spoke, you mentioned that, there's so much we don't know about Omicron. And one could be that if it proves to be much less, serious in terms of illness, that it may in some ways be a good thing that it takes over from Delta. You seem a little less optimistic that might be the case, given the vast increase in transmission that we're seeing. I mean, tripling the highest, case rate as an estimate seems a bit more drastic. So could you speak to that idea that, there's a chance that if it's, low enough in terms of severe illness, that this might actually be weirdly a positive for the community? And then, those thoughts on capacity and indoor spaces.
Mm-hmm. I don't know if Trevor or Alex, if you would like to address the former part of that question about severity versus transmissibility, and I'll finish with the indoor spaces bit.
Sure, I can, unless you want to handle anything, Alex. So my read on severity is still difficult. We definitely know that a larger proportion of cases are reinfections and breakthrough infections. We know that immunity, kind of both waning immunity and the immune escape from Omicron, is better at creating symptomatic infections than severe disease. So we've had kind of a shifting denominator because of this. It may well be the case that Omicron is also intrinsically less severe than Delta. We just don't know. We don't have the data on that yet. There's definitely a hit on severity due to this this immunity issue. And so it will be the case that the large Omicron wave happening in King County and in Seattle, there'll be a better case fatality ratio. There'll be fewer deaths per case, fewer hospitalizations per case. But what it matters is like, how many cases do we get? And what is that fraction of cases that end up in the hospital or end up succumbing to disease? And so we'll have a very big number and a very small number, and we're going to multiply them together, and we'll see how bad this will be. And we don't, that is definitely going to be a very large number of cases. Severity is unclear enough that it's not clear whether it's going to be very bad or not so bad. But like the spread there of possibilities is still quite large. There is a scenario where this is a good thing. I don't think it is necessarily the most likely scenario. That's the scenario where this happens to knock out Delta. That's not guaranteed. In 9 months, we could well have Delta and Omicron co-circulating together, and that intrinsic severity is lower than Delta. And so we don't know on both of those things at this point, but it could happen.
Thank you, Trevor. With respect to indoor gatherings, we are really at this point relying on our vaccine verification program to make indoor gatherings safer, and the guidance that we put out around improving indoor air, ventilation, filtration. And for people who aren't familiar with those, you can find it on our website. If you just Google Public Health, King County, Indoor Air Quality. You'll find some very good resources. And if, people need to use some judgment here. I mean, we're asking folks to avoid crowded indoor spaces, particularly if they can't mask. But at this point, not, again, thinking of any restrictions, but we can, we're not closing the door on any additional measures either at this point.
Thank you so much, Dr. Duchin. Let's take a question from Rainier Avenue Radio. You can go ahead.
Okay, there we go. Good afternoon, Dr. Duchin. How are you?
Doing well, Tony. Thank you.
This is Tony B from Rainier Avenue Radio, and we're getting a lot of conflicting messages. The fact that it is not supposed to be as bad as the Delta variant, and there's a report from the UK that says, wait a minute, it's too soon to say that. I've heard, and I wish I had the source here, that the Pfizer is not as effective. I don't know if you'll be able to answer those questions. Everything is just really confusing. However, everyone seems to agree that it is highly transmissible. And as we're talking about gatherings over the holiday season, do we have any evidence-based research, or can you tell us for any certainty how long the Omicron lingers in the air and continues to be transmissible, or if it's on a surface, how long does it live? How long is it transmissible?
Mm-hmm. Would any of UW, Alex, as a virologist, do you want to take a crack at that?
I mean, in terms of like Omicron specific data, we're still like basically 3 weeks, 3 weeks anniversary almost from when this was sort of initially detected and described as Omicron. So, there's nothing to suggest for this coronavirus that have different stability characteristics for that last question. I mean, I think we've sort of covered for the Pfizer's, and the different vaccines, there was some data that came out sort of in terms of slightly better, but just ever so slightly on the booster side. If you're talking booster, 3 doses versus 3 doses. But it really is about Moderna and Pfizer being significantly better than J&J and other vaccines.
Essentially, if this is airborne, how long is it transmissible airborne? If it is on a surface, how long does it live on a surface?
I mean, the original studies that came out in 2020 on the coronavirus suggested on certain surfaces it could actually be there for up to 3 days. So that's sort of the long range. Generally it's not that as long, but it does have stability on surfaces.
And I would thank you, Alex and Tony. I would just add that surface transmission is thought to play a really minuscule, if any, role in the community spread of this virus. It's primarily spread through the airborne route. So your question about how long it stays in the air is an important one. And the answer to that is it depends. It depends on what environment you're in. If you're outdoors, there's hardly any risk. It's blown away most times by the wind, the ambient environment. But if you're in an indoor location that's not poorly ventilated, and depending on how many people are in there, the infectious amount of virus that those people may have, and the ventilation system that environment has, and whether it has a filtration system, it could be a variable amount of time. But in the worst case scenario, it can also be on the matter of hours. We know, for instance, for measles virus infection, that people become infected after entering an environment where someone who had measles was, hours ago. And with COVID-19, there are also case reports of people entering spaces where other infected people had been but are no longer present, but becoming infected, presumably by a lingering airborne virus that just was not flushed out because there was not an adequate ventilation system. So the bottom line message is, if you're not in a well-ventilated place and there are people who may have COVID-19, that airspace could be harboring virus. You just can't know for sure. So the important thing is to ventilate all spaces to the greatest extent possible, and use masks as well to reduce your risk. Good quality masks, particularly KF94, KN95, and 95. They will both protect the person who's wearing them as long as they're fitting well with a seal around the face if there is airborne virus, but also they block virus from being emitted to others. And when all people in an environment are wearing masks, that's a double layer of protection. You're protecting it from getting out, and you're protecting it on the breathe in side as well. But for those people who want to just worry about their own protection because others aren't wearing masks, a good quality mask will also reduce the risk. But ventilation is critical.
Thank you.
And I just wanted to say that at UW hospitals, we've really invested and measured actual air exchanges in our operating rooms and many areas. And we all need to do that. We all need to mind that ventilation factor, which is critical. And this is why oftentimes I feel safer in the hospital than in other environments, because we know about the air exchanges.
Interesting. Thank you. I know we've got a handful more media questions here, but I'd just like to take one from the community. And I'm paraphrasing here, but a question about what would an Omicron spike mean for schools, and how do we keep our kids who aren't eligible for boosters safe? I'm wondering if we could just address that. And I'm sorry, back there. Let's try it again. So for you, Dr. Duchin, and I'm paraphrasing here, a question from the community. What
Okay. Yeah, I got it. I didn't know.
Oh, you got it. Okay.
Okay. I was seeing if someone else wanted to answer that.
Gotcha.
Well, Omicron clearly poses a threat to anyone, regardless of where you are in the community, including schools. That would be staff as well as students. And, the guidance that we've just given, the guidelines for schools, particularly around ventilation, are really important. Masking in schools, vaccination of all eligible students and faculty, really important. So, it's the same risk reduction measures, but really you want to make sure people are very compulsive about adhering to them to the greatest extent possible. The question about the younger children, of course, has always been how do we protect people, and not only younger children, but the immunocompromised patients in our community and older adults who may remain susceptible after vaccination even. How do we protect them best if they can't get vaccinated? And that is by the rest of us getting vaccinated, and also trying to make the environments in which those people have to go about their business as safe as possible. So that's, again, improving ventilation throughout the community. And those people themselves can take risk reduction measures by wearing high quality face masks that fit really well.
Thank you. And just one follow-up, any other important messages, and maybe this will go to you, Dr. NEME, for pregnant women? I know we've talked about that as really being important for vaccines. Anything you want to add on that?
Oh, absolutely. Yeah. Pregnancy is really, so any woman who's pregnant and unvaccinated carries a significant risk for complications, severe complications to both the mom and their babies. So COVID vaccination for a pregnant woman is an absolute must. And they're also encouraged to get a booster. And again, as Dr. Duchin said, as soon as possible. No matter where they are in terms of their pregnancy, they must get vaccinated and boosted. We hate to see complicated pregnancies and some of the devastation that we've seen in some families across the U.S. So we really try to prevent that.
Thank you so much for that. We'll take a few more questions from media. David Obelsh, you can go ahead.
There we go. Thank you.
Sure.
David Obelts, MT News. I have two questions. The first question is, with Christmas and New Year's coming, we're going to have a number of traditional testing facilities that will be closed over that period of time. What advice do you have for the public who would be seeking tests so that they don't show up in emergency rooms overwhelming those facilities? And then I can drop my second question after that because it's totally unrelated.
Yes, good question. I think if you don't have testing available in a community testing facility, the best thing you can do is to stock up on a few home test kits. I know that the solution that the current administration has come to at this point about allowing test kits to be covered by insurance is difficult. It doesn't work for everyone, and it's burdensome, but it helps to some degree. So I encourage people to get rapid test kits if they can and don't have access to, community testing facility, and use them. And they're very valuable for, right before an event as well. And we want people to be tested as close as possible to the time of any gatherings now, because first of all, Omicron is very rapidly moving, not only through the community, but in the body. You can test negative in the morning and positive in the evening. So getting tested as close as possible to the time of an event is really important. And if you don't have access to a testing facility in your community, using a rapid test is a really good alternative.
Thank you. Second part of the question: what level of
did you want to add something?
Yeah, I was just going to say that the UW Medicine, community testing sites as well are open, during the holidays. It's closed Christmas and New Year's Day, and then there are some that are even open on Sundays. So it's really just Christmas and New Year's Day that the community testing sites for UW Medicine at least are closed, but every other day they're open.
Thank you so much, Dr. Greninger. And you can, we'll put the link in the chat for the community to be able to take a look at the schedules for the testing sites. Really appreciate that.
Yeah.
Did you have a follow-up?
I do have a follow-up. What level of concern? Yes, I do. What level of concern should public and private employers have in being able to provide continuity of services as we go into January? Even if we have a lot of moderate illness, if there are a lot of people out, how much contingency planning should be done at this time for staffing issues?
Well, I'll start, and I welcome thoughts of my colleagues here. I think this is a good time to do serious contingency planning. We don't know what to expect, and we do not want to underestimate this virus. The early information about infections being mild is very encouraging. I want to believe it. I want it to pan out, but we just don't know. And so I think we need to prepare for a large wave, as has been described by Dr. Greninger and Dr. Bedford, large waves of people becoming ill very quickly together. And when possible, we'll try and get people guidance that will allow folks to return to the workplace as soon as possible. And I hope our CDC colleagues will help us and expedite that type of guidance. But I think people should plan for large-scale absenteeism, and best to be prepared and not have to go there than be taken by surprise.
Yeah, I would like to add that for UW Medicine, we've been planning, for a long time, but specifically now it's been intensified, particularly because we are seeing short staffing in general in the healthcare industry. And we cannot tolerate any degree of infection for anybody who's caring for patients. So again, a lot of effort in this regard.
Thank you. Elise Takahama, you can go ahead.
Hi, yeah, this is Elise from the Seattle Times. I'm wondering if you can, Dr. Duchin, talk a little bit about the kind of role that boosters will play in the next few weeks to months, and if there have been any conversations potentially about updating definitions of what it means to be fully vaccinated to include boosters.
Okay, thanks, Elise. The boosters play a really important role. We know that they increase not only the level of antibodies that fight coronavirus infection, but also the breadth of the immune response. And that means its ability to recognize and be active against a broader range of variant type viruses. So boosting with the current vaccines improves the immune response against not only Delta and Alpha virus and the other variants, but also Omicron. So boosting is important. Getting vaccinated with the primary series is critical. Boosting is important, and I think over time, our national policy-making bodies will have to decide what makes most sense with respect to the official definitions of fully vaccinated. However, the ACIP and the CDC, and we certainly also strongly recommend that everyone who's eligible for a booster get a booster. And you're optimally protected, once you're boosted. So at some point, this is a complicated thing because of the way the vaccines are licensed or are authorized by FDA to change, what is officially a primary series. But I would not be surprised in the future if, like so many of our other vaccines, the COVID-19 vaccine is just thought of as a 3-dose series. We have multiple other vaccines that are multi-dose, just like this. Dr. NEME, you may want to add to this.
No, absolutely. I agree. I'm very concerned about the large proportion of unvaccinated people around the world. And if you look at how Omicron kind of aroused, and it has to do with kind of the low proportion of vaccinated folks in certain areas. So as Dr. Duchin said, I see the primary series, the 2 shots, as critical. And obviously the booster is something that I strongly recommend as well. But particularly in the Latinx community, in the African American community, we're really lagging behind, even in the primary series. So that's a concern I still have every day, actually.
Thank you. We'll take one last media question. You can go ahead, Isolda Raftery, go ahead.
Hi there. I was hoping to hear from you all. What do you make about this idea that Omicron could be kind of the quote unquote exit wave from the pandemic? From everything you're saying here, it sounds like that's not at all how you're thinking of it, but I'd still like to get your thoughts on that theory that's going around.
Well, that's a great Dr. Bedford question if he's still with us.
Yeah, sure. So 3 or 4 weeks ago, I was expecting things to be arriving in endemicity. We'd have still evolution within Delta. COVID's not going away. Every year there will be a COVID wave or a COVID season, just like there's a flu season. Omicron kind of makes that significantly worse, where if we can have this kind of way of evolution where we have perhaps an immunocompromised individual, chronic infection, Omicron incubates within that, you have this variant that appears that's kind of far out of left field. Again, I am quite worried that in 9 months we'll have both Delta and Omicron circulating, and it's not that Omicron will kind of bring us out of this. I am very hopeful about immunity blunting severity, and so there can be lots of circulation of Omicron and Delta and the next thing like this that emerges. But I don't think that we're out of the woods. I'm imagining endemicity, meaning a lot of circulation. Per case, not per infection, not a high level of disease, but again, it's a very big number of cases each year and a very small number of severe outcomes from those cases. But that still will be something that we'll have to deal with as a society next year and the year after that, and the year after that.
And I would add to that, try and add something hopefully a little bit more optimistic, in that over time with these repeated infections and the seasonality that Dr. Bedford described, people will, and vaccinations that will have, either be boosted or more durable, responses, that we will, have more, our immune system will be exposed either to natural virus or vaccine, or a combination of natural infection and vaccine, without getting severely ill. And I think that's the state that we can sort of look forward to, where this is reduced to more or less something like an influenza-like illness, where very important for people to be vaccinated, particularly high-risk people, but that an infection per se is not a life-threatening event or a severe health event. And we're seeing now, even now with our vaccines, that an infection is not, in many people turning out to be a major problem. Now, we still have the long COVID thing that is not well understood, and we really need to learn more about that and the implications of infection of long COVID, and whether that will continue to be a problem as the population has repeated exposures and more experience and more vaccination. But things are a little bit hard to predict, but hopefully, over time, I think over time, this will become, less of a human health threat, but it's not going to go away very quickly.
Thank you very much for that. And do you have any final comments, Dr. Duchin?
Well, I guess, again, a reminder that vaccination alone is not going to be enough to limit the spread of Omicron that's underway. We need to layer on a combination of strategies that we know work to reduce the risk to individuals and to our community. And I understand nobody wants to postpone something they're looking forward to. I know the NFL, the NHL, the NBA, they're not happy about postponing games that they need to do to protect their players' families, and the communities that they play in. And once again, we all need to look out not only for ourselves, but for one another to decrease COVID-19 illnesses, to preserve our limited healthcare capacity for those who need it, not just for COVID-19, but for treatment of heart attacks, strokes, accidents, cancer, trauma, and other urgent medical problems. So please get vaccinated and boosted when you're eligible. Wear a high quality, well-fitting face mask. Avoid poorly ventilated and crowded indoor spaces. Limit gatherings if you can, and isolate and get tested if you have symptoms or exposed to someone with COVID-19. I really want to thank my colleagues from the University of Washington, both for joining today and for the incredible critical service that they're providing to our community.
Thank you so much. And I echo our thanks on behalf of Public Health Seattle and King County, and for media for joining today, as well as the public. With that, we'll close. Thank you so much for joining us.